of asthma management, because I don't, outside of kind of the work that Kevin's group is doing, I'm not aware of a community health worker force here in town or across the state of Missouri that's specifically addressing asthma, although somebody will probably correct me at some point. But what I want to talk a little bit about is some of the work that the Kansas City Care Clinic is doing, as well as several other area agencies here in Kansas City, and an effort that's also being replicated in Columbia and St. Louis and some of the outstate areas in Missouri, using community health workers to help manage various chronic diseases, and doing that in a clinic setting, in a home setting, and in the community. And to back up real quick, I was talking to Stephanie Moore this morning, and one thing she made me aware of was not everybody has kind of gotten up to speed on who the Kansas City Care Clinic is. So just by way of brief introduction actually to us, it may help some of you to back up. Before January 1st of this year, we were the Kansas City Free Health Clinic for the last 41 years. We've changed our name, and that's who we are. If that doesn't mean anything, then sorry. Okay, so I was going to go, I had planned to do a lengthy diatribe on why community health workers and what's the value of a community health worker. I think many of my colleagues today have really kind of brought that home, but I want to just hit a couple highlights. One of the things that the community health worker brings to us as part of our medical team, and really we like to think of them as an extension of our medical team. They link from the medical facility, whether it's your primary care facility or if it's your hospital-based team, they link to the patient. They bridge the gap back into the community. They're the part of the workforce that can help follow our patient home and do the care coordination beyond the doors of our facilities in a very effective way. They're a member of the community, they're trusted by the community, they're a part of the community, and they're often dealing with a lot of the same chronic issues that our patients are doing. Our current project at the Kansas City Care Clinic, we have multiple partners. We're working with St. Luke's right now. We have 2 of the FQHCs in town, a couple other safety nets, Cabot Westside, our own clinic, and we're currently in conversation with KU Hospital to provide community health work services to primarily uninsured adults with chronic illnesses. And what we're doing with them is really getting back to this idea of extending the medical team. We take those patients that are identified by the primary care team as in need of additional service, whatever that looks like depending on their disease state, and we take them and move them beyond the facility. One of our great examples, we have a diabetes specialist. He works in the home, and he does a peer level education program that's based on the American Association of Diabetic Educators. It's called AADE 7. He does this in a very peer level, individualized way. It's modular. He works with the patient to identify what their needs are, what their skill level is, and then he works with them on taking into account their priority level of what's important to them. But he does this in a way that moves beyond what we're doing with our nurse educators and our CDEs in our facilities. He goes to their home. He opens up their refrigerator. He goes to the grocery store with them and actually makes the education piece that we're trying to pass from provider down to our patient, he makes it very real. He makes it very tangible, and he makes it very easy for them to figure out what it really means to count carbs and what is sugar and how does this affect his A1C and all these things that mean a lot to all of us, even though most of us here are in the asthma arena. But to many of our patients, that doesn't make sense. Yes, they hear the information, and they may internalize it, and they may think that they understand it, but once they leave our office, they probably don't remember it, and if they do, they didn't really know what it meant in terms of going into their home and within their limited budgets oftentimes, how they can purchase those foods to do what it is that we as providers are suggesting they need to do to make themselves healthier. So, I'm talking about diabetes, and we're here at an asthma summit. So, the thing I want you to take home from kind of my little piece of this summit is that as we talk about what we need here with asthma management, and as we talk about the need to have a community-based workforce that is skilled and well-trained and connects well with our patients, and that our patients are comfortable opening their doors to them, I want you to know that there's a substantial infrastructure being already built in Kansas City with community health workers. The Kansas City Care Clinic is doing this work. We've got partners over at Truman Medical Centers who are doing work with community health workers. El Centro is an agency here in town who uses Promotores. The Rural Healthcare Collaborative is using community health workers for diabetes management. The UMKC School of Nursing and Departments of Clinical Psychology are doing some research around the use of community health workers and partnering with the African American Church community. Sam Rogers and the Mexican National Consulate here in town are also doing work with community health workers. And then we've got partners that are replicating that same work in Columbia and St. Louis. And we've got a regional collaborative of providers that are working with the Mid-American Regional Council. And we meet monthly as a collaborative group, bringing together and discussing the topic of what is the standardization of what a community health worker looks like in Missouri. What do we need in terms of training? We've brought in the Metropolitan Community College system here in town. They've developed a core curriculum of what the training should be for a community health worker here in Missouri. That curriculum is being expanded to community colleges currently in St. Louis and is available to be distributed or disseminated throughout the state of Missouri. So it's here, that workforce is here, it's available, it's very dynamic, it's very trainable, and it's a great part of the extension of our primary care system or our hospital systems as we're looking at a comprehensive asthma management system. Thank you.
All right, that was excellent, thank you. And that's all of those panelists together tell us that there's been plenty of activity, particularly in the state of Missouri, that there are clearly effective programs that are doing great work, and that there is a workforce of community health workers that have been identified in other communities as being an effective workforce for working on asthma care. So we need to connect all of the dots that our panelists represent. But we'll do that as we talk this afternoon, but I want to see if there's any questions while we have our panelists up here, just to see if there's any questions that we can quickly answer while we have them. Yes?
Yeah, I have a question for Dr. Portman. You brought up James, and then you said that you did a healthy home assessment. So, by the fact that you said James got better, did they do some sort of remediation? Did they take care of the rodent infestation?
Not yet. We haven't done the home assessment yet. Right now he's better because we gave him some medication management and put him on dynamic dosing just so he could get to camp. And that'll work for a while, but he's short, he's taking lots of medicine, he's got this huge bag. That's not a long-term fix. The long-term fix is to get rid of the underlying problem that's making him sick to begin with. That's where we need Kevin to go out to the home, tell us if there's a lot of mold problems, where are the rodents coming from, get the community resources we need to help them with the intervention to get rid of the rodent infestation and to fix whatever other problems there are so that James can get healthy.
Well, and as Dr. Francisco said too, in following that priority, are they adhering and complying with their management plan, their medical management plan, and then is the proper dosage, are they seeing good inhalation technique, are they getting the right medicines that be delivered effectively, and then dealing with the environment at the same time.
Yeah, but the key thing is if we fix the environment, maybe he doesn't need to be compliant with the medications. Wouldn't that be better?
That would be even better. But it's certainly the combination of those. Yeah, what's your hand?
I have a question. As we start to do these environmental assessments and we make these discoveries, does anybody have any experience or suggestions? Because then you get into, is the person a homeowner or a renter, and then people fear losing housing, especially if you're a tenant. If you say that there's an issue, where's the cost lie in remediating that issue, and are there resources? So how do you begin to deal with, you've identified the environmental factor, but now how do you actually fix it?
Well, fortunately, we've had a couple of healthy home-related organizations that have been actively working with families, whether they live in owner-occupied homes or rental homes. And I can tell you from our experience that it's a balance. We have had some landlords who were very willing to work with us in recognizing that these things could be affecting the occupants, especially a child. They're concerned about the welfare of that child. And we've had some that didn't want to work with us very much. At the same time, because of HUD's support in providing healthy home funding for us, and now we have some foundation grant funding to support home remediation. When we get into landlord-tenant situations, one of the things we try to do is work with the landlord and say, we have some dollars to fix some of the things that we've identified in this house, but there are some other things that we're asking you, the landlord, to fix. And the incentive being, we'll fix these things with our dollars if you'll fix those other things. Now, we try to also divide that and say, these are the things that are partly related to how we teach the patients or the family in occupying the house better, cleanliness and those kind of things, better management of the home. But we also recognize that some of the things we see are code violations, and they shouldn't be there in the first place. So we really try to use our incentive, rather than just turn the landlord in, complain about the code violations and make them pay fines. If we can incentivize it and encourage them gently to fix these things that are clear code violations, safety hazards, or other kinds of health hazards that might be contributing to some of the environmental problems, we'll help address some of the specific problems. And I know that Kim could tell you the same thing, and June was on the phone, that they have a similar kind of effort. And you work with
I
the...
just wanted to mention,
Yeah, go ahead.
it really depends on your landlord-tenant laws, but then it's one of the issues that I may talk to you outside of this as well. That's one of the issues that we have been experiencing, is that some landlords are just eviction. And so it's a legitimate concern to about.
Well, go ahead.
Me?
Yeah.
Okay, so I have a double, one question and one response. You're from St. Louis County Health Department. So we met recently with the Community Action Agency, which is the Department of Energy, I think, and they have remediation money. Okay, so we talked to them, or Urban, it's the Urban League of the city. So, you know, if you want more information.
A great
But
networking
Dr.
opportunity.
Portnoy, again, so James, will this Healthy Home visit be paid for by a grant, the grant money that you have, or is he now qualified for the health home in Missouri because he might have two of the identifiable diseases, asthma being one?
I don't know. Right now, I just want to be able to order the test, and if he's covered by one of the Medicaids, hopefully that will be covered, and it will be a service that he'll be able to get access to. We do occasionally get grants, but we don't want to rely on getting grants to pay for these healthcare things. We want it to be a routine component of healthcare service. I can order an x-ray, I can order a blood test, I should be able to order a home assessment for those patients in exactly the same way and have it be reimbursed by the health plans the same way those other things are. This is a cost-effective thing, but it's something that's not traditional, and therefore the health plans need to think differently about how we pay for things. That's where you all come in. Those of you who work for health plans, we need your help. You need to think differently. You need to consider the possibility of paying for environmental assessment. We'll work hard on getting the remediation done. We're not asking you to get into the home repair business, but at least let us figure out why the patients are so sick, because that way we can have some idea of where to guide the home repair, the remediation.
I just wanted to respond to your question. Boston has an interesting program where physicians seeing low-income patients, and they suspect there's an environmental issue like pest infestation. They have a relationship with the health department to get a code enforcement official to go to that property and to inspect it and to require the owner to comply if they find issues. So it doesn't mean the owner wouldn't retaliate, but at least you have that a level between the patient and the owner. You've got the physician. And then Kim mentioned their program using community development block grant money. If you can tie in, you know, we at HUD would love to see that more, where where local organizations are tying into that community development block grant money, some of which goes to low-income home rehab, and prioritizing it and for cases where you have a kid with poorly controlled asthma, mold problem, etc. So there's creative things you can do locally.
Well, community development block grant funds pay for emergency home repairs and pay for small home repairs, and a lot of community development corporations and neighborhood associations will have those funds for their neighborhood, and we have been reaching out and have some partners locally through a healthcare foundation grant that we have that specifically works with them and allows them to apply some of their funds to the same homes that we've got a little bit of funds from this foundation grant. So we're going to have kind of a soft break here as we now organize for your groups. Thank you very much to the panel up front. Please give them another round of applause. We have snacks and drinks in the back. We can take a brief break, but we're going to get together in groups here. We're going to be getting out the poster boards here for you to work at your tables. So we'll give you some instructions here in about 3 minutes.